Okay. Hello. Hello, everybody. I hope that you sleep well to start this third day of the course. Today is live surgery, and the first case is nasal polyposis. Uh, he's a man. He's 40 years old, okay, and it suffered despite the medical treatment from nasal polyposis with a stad 3 to 4 on both sides. So it's a good indication to do the surgery due to the fact that the local treatment and short cure of corticosteroid are a failure. Uh, so I explain the patient the objective. The objective is to recover the nasal comfort, of course, during diurnal and nocturnal period, and to restore the olfaction, if it's possible, and taste. Okay, so in fact, when I explain, I do a diagram like that, okay, and when I draw this diagram, I continue my speech and my information, and this diagram is complementary to my discussion. Okay, so it's very important to uh, to give the information for the patient, allowing him to visualize in space his disease and the surgical action. Okay, so I explain the different step of the surgery, the condition to do it, okay, and the normal evolution during the immediate postoperative period, and its participation. I explained that the bed rest, the work stop, um, the sport stop during 4 weeks, um, the evolution of the pain, the level, the intensity of the pain, and medicine to counteract, okay, the necessity to do some nebulization, nasal irrigation with large volume, with seawater, and um, to take uh, its to take his uh, daily treatment um, in my department uh, uh, 15 days after the date of the surgery. So he takes again the spray of corticosteroid uh, 15 days after the surgery. So before to start, it's to explain the indication. So before to start, of course, we perform a CT scan, and we're going to do the checklist. Um, we are going to do the checklist together. So I see in the first step the coronal slice. Okay. Oh non, ça marche pas. Putain de connard.
anglais. Hein. Chier, ces trucs, c'est de la merde. Bon, on recommence. Alors, c'est quoi les codes? Moi, je foutrais tous les informaticiens au goulag. Alors, we are going to start the checklist. So, the first is to show the lamina papyracea, okay, to search the essence due to an old trauma or due to previous surgery. This is not the case for this man. Both lamina papyracea are completely okay. So, on axial view, dans l'autre, non, l'autre, là, celle-là, là, ok. Il y a, ah non, ça c'est la lumière. Alors, ça c'est la lumière, ok. Ça, voilà. So I control here the complete integrity of the lamina papyracea, so it's good. So I come back in coronal view to analyze the shape and the level of the ethmoid roof. So this is a stair-shaped ethmoid roof on both sides. The size of lateral wall of olfactory groove is close to 4 to 5 millimeters. Okay, so be careful in this area and don't incline your forceps on medial line, of course, to avoid any trauma on this thin lamella. So the ethmoid roof is almost at the same level and they're almost the same shape. Okay. Next, the olfactory clefts are free, so we haven't any hematoma. So this is a good news. Okay. And I'm going to assess the difficulty and the danger to perform the middle enterostomy. And as you see, the distance between the back of the inferior turbinate and the orbit is very huge, so it's very easy to do the middle enterostomy here, in this case, on both sides. Okay? So now, in axial view, we are going to check the root of the optic nerve and the carotid artery. So here we have the optic nerve on the left side and on the right side. Okay, and the optic nerve is in close contact with the sphenoid, and a little bit here due to these expansive Onodi cells, not expansil, not expansive, of course, expansil Onodi cells. The optic nerve is in close contact with the posterior part of the ethmoid and the superior part of the left sphenoid. Okay, so be careful in this area. Okay, and the carotid artery is here, and you have the intersphenoidal septum attached on the sheet of the left carotid. So be careful if you want to penetrate in this left sphenoid, but it's not necessary in this case. Sphenoidectomy is not necessary. I remind you that the nasal polyposis is not a sphenoid disease, but this is an anterior ethmoid disease. Okay? So the program is to do the both radical ethmoidectomy and one septoplasty due to the fact that the surgery starts at 8 o'clock. The right, no, sorry, the left side is already down, and the septoplasty is already down, not completely. The destruction phase is step is already done, but the rebuild step is not. And I'm going to show you at the end of the procedures. So now we are going to do the right ethmoidectomy. Okay. So, ils ont la vision. So, um, I'm going to show you the first side. So, the ethmoidectomy is already down. So, uh, I'm going to show you the result. You have here the middle antrostomy. Okay, the inferior turbinate. Okay, so uh, the maxillary roof, so the floor of the orbit, the junction between the floor of the orbit and the lamina papyracea here, which is completely flattened, of course. And here, of course, I cut the middle turbinate. It remains some pathological mucosa here. Yes, thank you. And so this is the section of the middle turbinate, and here we have the anterior surface of the sphenoid sinus on the left side. Voilà. Like that. Okay, this is the anterior wall of the sphenoid sinus because you have here the cavum and the coronal arch, and you continue to climb in the nasal fossa, and you have here the anterior wall of the sphenoid sinus. So, lamina papyracea, and here you have the roof of the ethmoid. Okay, here it was the passage of the anterior ethmoidal artery, and I coagulate the artery. Okay, and you have anteriorly the infundibulum of the frontal sinus. Don't forget that you have cells between the artery and the infundibulum, and this is the posterior meatal cell. Systematically is like that. So the posterior artery is not visible, so small branch here, but it's inside the bone. Okay, here the mucosa is completely removed. Okay, so this artery is coagulate. Okay, and we have any important bleeding. So on the other side, after the septoplasty, it's easy to observe stage 3. Okay, the middle meatus is completely fulfilled by polyps, and we are going to remove it with the straight forceps, fine straight forceps. Thank you very much, Estefania. So I searched the, the pedicle of the polyp to remove it in one time because it's boring to do the debulking. Okay, and I remain in the middle meatus, and my forceps is um, parallel to the the orbit and the middle meatus, the middle turbinate. Okay, continue to remove it, this polypoid mass, allowing to create a workspace. So you can see the middle turbinate here and the encinate process in front of you. Okay, this is the encinate process here. It's a little bit bulge, probably due to secretion inside the maxillary sinus. Okay. Okay. It remains. So now it's time to do the uncinectomy. Ah. Là. Alors, here this is the middle turbinate, and here you have the encinate process. So I cut. Don't forget that you need. Do you see the bubble? Okay, I cut the 3 layers of the encinate process, and I'm medialized to next introduce the straight scissors. Okay, in my incision. Okay, to cut the attachment of this process. Um, yes, this is the result of my action. So now it's possible to introduce my suction tube in the maxillary sinus, and next with the straight forceps, I catch the superior part of the uncinate process. Okay, with more or less polyps, and I catch downward and posteriorly, avoiding any stripping of mucosa when it's not um, uh, wanted. Okay, so 45. Okay. Okay. It's completely different. Oh yeah, look, okay. The middle antrostomy is almost down, so I'm going to try to enlarge anteriorly with the backbiting forceps. And I, I don't close completely my forceps to catch and elevate the remnant part of the antenate process like that. Okay, and I close it when I'm able to see what I want to remove. Okay, good. So there is a lot of polyp, but it's normal because this is a stade 3 to 4, intermediate between 3 to 4. Okay, so now to increase my visibility, I'm going to cut the middle turbinate. So as I showed you yesterday, I cut posteriorly, close to the tail. Okay. Next, I change my orientation and I'm introduce my like that, my scissors on both sides of the superior attachment to cut horizontally. Okay, and to catch downward in the same time these anatomical structures to reach my posterior incision one time like that. Okay, in one time. Okay. You can observe that the bleeding is not too intense. Okay. The olfactory cleft is fulfilled by polyp, so I'm going to remove it. Yes, because in fact this polyp comes from not the exactly the olfactory cleft, but it comes from the superior meatus. Okay, so it never attached compared to the hematoma on the uh, on the roof of the nasal fossa and the olfactory, notably the cribriform plate. So here, this is the section of my middle turbinate. So now the bulla is not really visible. So I have here my landmark with the middle antrostomy. I touched here that I have the roof of the maxillary sinus and the stair shape, the junction between the roof and the lamina papyracea. So here, this is the ethmoid, so I can crush it to remove the first step of. Don't forget that the decision in endoscopic surgery is 50% due to the vision and 50% due to the palpation. Okay? So it's very important to palp the anatomical structures. So this is the result of my action. Okay? So here I have my middle antrostomy and the start of the ethmoidectomy. Ok. De quoi voilà. Okay, so here I have the middle antrostomy, and here, okay, this is the cells, and I'm going to search the remnant landmark, which is the lamina papyracea, and I think it's close. Yes, it's here. So I continue to remove this pathological mucosa. To search each landmark. Okay, so it remains some uncinate process here, and it's very important to remove it to gain in the visibility laterally. Each millimeters are important to well see the operative field. Okay, and I keep my forceps sagittal all the time. Okay, just a little bit inclined. It's possible here because I am in front of my middle antrostomy. Okay, but usually take care to keep your forceps sagittal. So just behind my forceps, I feel the resistance of the lamina papyracea. I'm going to show you. Um, okay, yeah. Sagittally, look, this is the lamina papyracea. Okay, so now this is my lateral landmark. My medial landmark is the middle turbinate. So this is the lamina papyracea. Okay, this is the roof of the maxillary sinus, and the junction between the both is here. So it's possible to remove it. What? Straight forceps. Okay, it's not dangerous to do this like that because you control the different anatomical structures. So you have the stair-shaped junction between the both anatomical structures. So here, the cavum, the coronal arch here. Okay, the olfactory cleft. Now we are going to reach the posterior ethmoid. Okay, here. So with the 45-degree forceps, here this is the lamina papyracea, and here this is the middle turbinate. So I'm going to remove the first cell of the posterior ethmoid, like that, to reach the next landmark, which are the anterior surface of the sphenoid sinus and the skull base. Okay, so it's okay. I continue to remove this pathological mucosa and the different polyps to steadily reach posteriorly and superiorly to reach this landmark. Okay? And steadily, it's possible to increase the visibility. I think it's probably here the limit, but I don't know because I have here the anterior surface of the sphenoid. Okay, so oh, this is at the same level. Okay, so I continue my dissection anteriorly. I keep my forceps always sagittal. Don't forget. And I expose steadily the remnant part of the okay lamina papyracea, là, here, and probably here is maybe the school base, but I don't know for the moment. I continue to remove the different piece of mucosa in front of me, avoiding to operate in a deepness and narrow space. So I sculpt my rectangle like that. Okay, like that. Okay. So this is another cell here, and I'm going to probably show just behind the school base. Yes, yes, yes. I think this is the school base now. So it's very important to remove all piece of pathological mucosa. Don't forget on the CT scan that school base, the shape of the school base was a stair shape, is a stair shape. So, ah, et ça doit être plein. Ouais, on change. Ok. Là, you will see here, this is the anterior surface of the sphenoid, the junction with the lamina papyracea and the school base. So I am in a good location and I continue my dissection anteriorly because in fact this is not finished. I have here the lamina papyracea, okay, and I continue to follow my landmark, okay, and to remove all piece like that of pathological mucosa. Um, Often and most of time the posterior artery is uh, hidden in the bone. So now I complete the anterior ethmoidectomy. It's not dangerous here because I am not on the school base here, because here I am anteriorly compared to the infundibulum of frontal sinus. Okay, so it's not dangerous here to introduce just beyond the superior attachment of the middle turbinate your forceps and to enlarge it like that to increase the visibility of the anterior part of the anterior ethmoid. Okay, like that. It's very useful to do this uh, gentle action on the middle turbinate to enlarge the visibility in this area. Okay, so here the posterior ethmoid, the skull base, and the remnant part of anterior ethmoid. So we continue to remove gently different cells, and probably I'm going to show to see the anterior ethmoid artery. Okay, so I follow my middle turbinate like that, and I follow the lamina papyracea, and I keep my forceps sagittal. Okay, go. Ah, maybe, maybe or not. Maybe because this is the root, I think, of the artery. So I continue anteriorly. Okay. Okay. We're going to wash again. Yeah, good. Okay. Forceps, please. Mm-hmm. Yes. Okay. So you will see here. Uh, give me forceps. 45. Yeah. Yeah, you will see here the school base like that, and he. Oh. Here you have the passage of the anterior ethmoidal artery, like that. This root is oblique, okay, lateral to medial, because this is a branch of ophthalmic artery, okay. And here um, it's not recovered by bone, look, supple, okay, but this is an artery. The wall is resistant to trauma, so it's possible to dissect it, okay. 45 longue. Look, it's passage. On voit bien, hein? Okay. And I'm going to search the infundibulum of the frontal sinus, but I think it's here. Yes. Okay. So here, the passage of the artery. Marvelous. Oh, mais que c'est beau. Oh, bon. Look, the size of this artery. The diameter of my suction tube is 4 millimeter. Look, the diameter of the artery. Okay? It's a joke. It's not a danger. This is a very small artery. So, if you do some injury, you must do, like a surgeon, hemostasis. So, due to the previous septoplasty, the nasoseptal flap is a little bit boring to show tranquillement the different. Ah, là. Ok, là. Yes, le longus. Okay. So, here you have the artery, the posterior meatal cells, and here you have the infundibulum of the frontal sinus. Look, okay? So, stop to trauma the infundibulum, avoiding, of course, stenosis. So, we are going to control the remnant area of the ethmoidectomy. Okay, so oh, 45-degree forceps, no, short, penetrated. So I remove this one at the entrance of the maxillary sinus. It's a detail, of course, but the quality is on detail. The education is on repetition and the quality is on detail. Okay, very important to clean completely this pathological area. So this is the lamina papyracea, of course, and here this is the relief of the lacrimal sac. Okay, so it's good, good, good. Okay. So now we are going to finish the septoplasty. Okay, the olfactory cleft is now free. Okay, it's free. You have the superior meatus here, like that. Okay. So, correct. And in the cavum, good. Okay. So now, I'm going to show you the last step of the septoplasty, which is to rebuild the anterior area of the septum. So we are going to show you with the endoscope. Of course, I never take it to do this surgery, but for the demonstration, it's very useful. Okay, so here we have the junction between here the anterior nasal spine. Sorry. Ouais. The anterior nasal spine. Mets-toi la tête à l'envers. Here. Here you have the anterior nasal spine here, and the caudal border, the inferior border of the quadrangular cartilage. Okay. Behind, okay, the septum is completely destroyed, and we keep, of course, the coronal arch, but the remnant deformation are completely removed. Only the premaxillar maxilla, only the premaxillar maxillary crest. Okay, so now the job is to adjust the height of the anterior septum. Okay, and you are going to judge the good height, and it's too high. Okay, so I'm going to modify a little bit uh, the shape and the size. D'abord, pince à cartilage, because it remains soft tissue here, and I remove it on both sides to see well. Okay, so the anterior nasal spine is flat, so I decide to cut the height of the septum, and be cautious. Okay, like that. Forceps, please. Mhm. No. Okay. So it's good. I control posteriorly. Okay. It's good. So now we're going to fix the septum on the nasal spine. Okay. Now the height is correct, like that. But you need to fix it on the nasal spine, avoiding any supralobular depression. So to do it, I cross the nasal spine upward to downward. Okay. Next, the assistant takes the distal extremity of the fil. Je sais pas comment on dit. Next, I'm going to SP section 2, please. I'm going to cross the quadrangular cartilage at the good distance, at the good anterior-posterior distance, because you must anticipate the notch, and the passage across the nasal spine must be in front of the passage in the quadrangular cartilage. So it's here, and I catch my needle on the other side. Okay, and next I must do a third passage in upward to downward. Okay, again in the nasal spine, like that. Okay. Yes. Now, notch. Look here. Notch is possible. Okay. Yes. So, before to do it, I control the good position of the septum. Yes. The absence of supralobular depression. Okay. And after, with help of the assistants, we are going to do the notch
exactly uh, position notch to obtain a straight sagittal solid anterior septum. Okay, it's very important to, yes, have this quality criteria. So now, with my Kilian elevator, please, thank you. I'm going to show you the result like that. Uh, uh, okay, so the septum is sagittal, straight, and fixed on the nasal spine with a very solid notch. Okay, so it's good. And now you are able to control the aperture of the nasal valve. Okay, so the septum is correct before, in front of, and after the nasal valve to reach like that the area of uh, the respiratory corridor. Don't forget also that the air during the inspiration describe its route describe a curve, penetrates in the nasal fossa at almost 45 degrees. The air is next accelerated by the nasal valve and turn in front of the middle meatus downward to reach the cavern. So the air describe a curve downward and posteriorly. Okay? So on the opposite, okay, the nasal valve is correct, okay, and the aerated corridor also. So, okay. So we are going to close the hemitransfixion incision to remove the different blood plots and to put in place. Ouais, je vais fermer. Attends. Il faut que j'aspire les cailloux. Et. Vas-y. Okay. So I'm going to close the hemitransfixion incision with first yes. Ah merde. Faut prélever le sang. On va montrer ça. Quoi? Ah, il va venir ici. Ok. On va faire comme si on allait fermer. Puis après, tu. Hein? Je vais mettre le numéro 5, tu le réserveras. Okay. So, here, the incision is now closed, and due to the fact that we perform a septoplasty, I'm going to put in place some nasal packing, even if it's not necessary. After a complete ethmoidectomy. So this is a number 8 mirror cell, and this mirror cell is a little bit cut in the posterior part, like that. Okay, avoiding completely blocked um, avoiding, I don't know the word in English, to faire ventouse,
Section.
a suction effect when you remove it around the corner arch. Is the reason why we reduce its length. Okay. Next, we inflate the mirror cell with cold water. Okay. Never use hot water. And this mirror cell stay in place 2 days. So the removing will be Friday. Okay. So now the operation is finished, and take my phone if you have any questions. Alors, faut que je prenne mon téléphone. J'appelle qui? Gerson. Ouais, Gerson.
Oui, si tu veux, oui.
Ouais, s'il te plaît. Monsieur de Gaboury, donc finir ça aussi.
Ouais, attends, je réponds aux questions et je viens.
Oui. Vous le faites systématiquement scylastique maintenant? Le PF? Pas forcément.
Pour le plaqué en haut,
Pour le paquet?
bah, c'est mieux.
C'est mieux.
On va sûr que ce sont plaqués. Ouais.
Oui.
Et oui, mais
Okay. So I'm going to show you a clinical case um, during the time needed for the needed to change the patient, of course. So it was another nasal polyposis. Okay, and you have here the CT scan. You have small hematoma in the anterior part of the olfactory cleft, and this is uh, stage stage 2 to 3, depending on the side. Okay, the patient and the nasal polyposis are resistant to the medical treatment, um, local and general medical treatment. So this is an indication to do the surgery. So um, you will see the coronal plane. So I repeat the checklist, the lamina papyracea, okay, um, the distance between the back of the inferior tuminate and the orbit, it's very used here, it's not difficult. The position of the uncinate process, the presence of the absence of the landmark, the shape of the screw base, the width of the ethmoid, and the number of cells and the thickness of the bone, which is usually thinner by the disease. And here, for example, in this case, sorry, uh, you have an odonty cells here on the right sphenoid sinus. Yes. On the right sphenoid sinus. So be careful because when you are in the deepness of the posterior ethmoid, you are in close contact with the carotid artery and the optic nerve here. Okay. So be careful with this specific anatomy of ethmoid. So, but in this case, I think that is not necessary to go in. You can see in axial view uh, the shape of the ethmoid, the shape of the septum, okay, and the size and shape of the sphenoid. And look on this slide, you have a discrepancy between the left and the right side. Here you have the sphenoid sinus on the left side, and look, the anterior surface of the right sphenoid sinus is a little bit posterior from the left ones, and you have an overlap of the, you will see here, overlap of the onody cells close to the left sphenoid sinus, okay, and right. So in this case, look on the right side. Here you have the onody cells, which overlap the right ones, the sphenoid sinus, and posteriorly, this is the sphenoid sinus. So be careful on this side, okay? And this is the endoscopic view. Okay, so this is the first operation to treat this resistant nasal polyposis. So this is stage 3 to 4, 3. Okay, the cavum is free, and we are going to do the same thing than the previous patient. Okay, but this video is more pedagogic, in my opinion, due to the fact that the bleeding is lesser than the previous live demonstration. Okay, so we have a bulla terminate, so it's not dangerous or constraints, but I'm going to cut it in the first step because it due to the bulla is not possible to operate the middle meatus, so I prefer to remove it. Okay, I prefer to remove it. Here the bleeding is controlled. Okay, and I catch the posterior part of the middle turbinate and I remove it downward and posteriorly. Okay, to avoid any injury of surrounded anatomical structures and tissue. Okay, now as you can see here, the workspace is considerably enlarged, so it's easy to start the ethmoidectomy. So here, this is the junction with the here with the uncinate process as a frontal branch of the maxillary bone. Um, yes, and you proceed as the same manner. And I'm going to introduce the movable part of my inside my incision to catch the superior part of the uncinate process and to remove downward and backwards, okay, in one time. It is very important to do the different steps in one time. Okay, it's very boring to repeat each step. So I know that it's not easy to learn and easy to do, but steadily, when you are going to increase your know-how, you will become able to do every maneuver in one time with efficacy and in good condition and safety. So here I enlarged the middle antrostomy. Okay, I enlarged it. It's not sufficient here, so I continue to do it. Before to start, another step. Each step must be complete before to start another one, because in fact the job here is not to remove the polyp. Of course, it's to remove the polyp, but technically, the job is to find the landmark. For the surgeon, for the patient is to remove the polyp, of course, but for the surgeon, the game is to search and find the landmark. Okay, so I continue to remove with the backbeating forceps the remnant part of the uncinate process. Yes, and of course, often the maxillary sinus is often normal in nasal polyposis. Don't forget that nasal polyposis is an anterior ethmoid disease and not a maxillary disease. If the maxillary sinus is healed, is a consequence of the original disease. So now I starting the ethmoidectomy by the bulectomy. Shall I? Okay. And as I said and performed previously in live surgery, I'm going to remove the different debris of pathological mucosa, polyps, wall sheets of bone, to enlarge the ethmoidal mass. And each time I control, yes, I control here the landmark. This is not the middle turbinate, this is the lateral wall of the bulla. So I can remove it in good safety condition, because in fact my medial landmark uh, is medialized. Okay, so medial wall of the middle turbinate is closed, but this is not. Yes, so it's a reason why it's very important to analyze. So be careful here. Yes, to analyze um, the day before the surgery, the CT scan, uh, to start your surgery with fresh data, because in my practice, I receive the patient 3, 4, 5 months before the surgery. So of course, with these delays, you are completely out the case when it's the day for the surgery, of course. So you need some reminder, and it's a good attitude to do the quality control of your indication, and the quality control with the checklist of pitfall, to reduce the stress of the procedure and to avoid any accidents and morbidity. So here I do the posterior ethmoidectomy. I keep my forceps sagittal. Okay. And look, I free the cavum. I'm going to see, I'm able to see now the coronal arch, which is the posterior landmark. So I keep my forceps anterior to the sphenoid to free the posterior ethmoid. So I decide at this time to continue to reduce the middle turbinate, because this remnant part is unuseful for the function. And I remind you that cut the middle turbinate doesn't provoke reduction of smell and taste recovery. Okay, you haven't correlation between the capacity of the patient to recover olfaction and taste with the presence or not of middle turbinate. So we continue to remove the polyps and the heel mucosa. Okay. Under the control of the view, avoiding to introduce your instrumentation in narrow and constrained area and location. Yes. Well, here the bleeding is very gentle. Okay. And I think we can see now the Ono cells. I don't know if it's the left or the right ones, but we are going to remove this piece of mucosa to expose the posterior anatomy of the ethmoid. So I need to enlarge my operative field and to remove this part, yes, part of the ethmoid. I am not close to the skull base because look, laterally on the screen you can see the level of the orbital floor. So I am far for the moment from the skull base. Okay. So we continue our cleaning program. And here I search above and behind the superior turbinate, the natural osteum of the sphenoid. And look, I remove the superior turbinate with a small hemorrhage. This is not an important hemorrhage, and you haven't any retraction of arteries. This is a branch of the sphenopalatine artery. Okay, and most of time, this bleeding stops spontaneously, but due to the spasm of the artery. So don't forget to do the hemostasis at the end of the procedure. I advise you to do it immediately, avoiding to forget at the end of the procedure. So, as you can see, I enlarge here the right sphenoid sinus, and you can see, as we saw on the CT scan, the discrepancy between the location and size of the sphenoid sinus and the posterior part of the ethmoid, because you have an overlap due to the onodicels, an expansile onodicel. So now I have my posterior landmark with the coronal arch, the anterior surface of the sphenoid, and the sphenoid sinus, and the onodicels. I continue to enlarge it. I think it's not necessary, but I prefer, okay, to enlarge in good safety condition because I enlarge inferiorly and medially. Okay, the danger in the sphenoid sinus is lateral and superior. Okay. Okay. Now we continue the posterior ethmoidectomy to reach the skull base. So for the moment, I think we are far from the skull base, and it's necessary to continue the ethmoidectomy. Okay. So the aspect of this part of the ethmoid is very typical. It's completely different than previous one. You can see here a flat area, the junction between the anterior surface of the sphenoid and the flat area of the roof of the ethmoid. So now, as you can see, this is the skull base. Okay, so I continue to clean this area, and next, this is my deepness, my superior landmark. So I continue to remove the different debris of mucosa and bone to have the posterior part of the rectangle. Next, I come back entirely to crush the different cells. Okay. Good. Good, good, good. So this is the remnant lateral part and superior part of the uncinate process. So I remove it. And I follow the level of lamina papyracea. Okay. So be careful at this location because laterally you have the lacrimal sac, so it's fragile. The angus bone is fragile. Okay. Don't push and crush with your suction tube. So now I complete the cells extirpation of the anterior part of the ethmoid. Le suivant est là. And in the same manner than previous patient, surrounded by how landmark, I crush and I keep my forceps sagittal to follow the skull base now because it's well visible. Yeah. Okay. Next, we continue to remove. Okay. The skull base is well visible. And as the previous patient, I'm sure we are going to discover the anterior ethmoidal artery because on the CT scan, it was well visible and doesn't covered by bone, by a sheet of bone. Okay. So I think that will be possible to observe it in the cavity of nasalization. So I continue to crush the anterior. I see the anterior ethmoid artery. I don't know if you see again, but me, yes. Okay. So I don't know if you, yes, this is the anterior ethmoidal artery here. Okay. Without any bone sheet around this anterior, posterior, and inferior part. So be careful. This artery is solid. Okay. Injury are obtained with the forceps, but not with the suction tube, in fact. So you can see now the terminal vision of the, this is the sphenoid, maxillary sinus. You can see the rectangle. This is the maxillary sinus here. You can see the rectangle of the ethmoid after the ethmoidectomy. So, as you can see here, For example, look, with the endoscope, as you can see here on this magnification, I said yesterday that you need to rebuild the three-dimensional model of the sinus in your mind during the operation, surgical procedure, because in fact, you see your operative field with an eye fish, with a monophthalm eye fish. Look, on this screen, you are able to see the coronal arch, which is completely posterior, the sphenoid, the entrance of the sphenoid sinus, which is completely posterior and superior, the entrance of the maxillary sinus, which is lateral, completely lateral, and the cavity of the ethmoidectomy, which is completely superior and anterior. So, with this eye, you are able to see in front of you and in the same time laterally and superiorly. It's impossible with a human eye. Okay, so this is the first characteristic of the magnification, and the second one is that you lost the three dimension and you lost the deepness of the operative field. So you have all anatomical structures on a flat image. Okay, so you need to rebuild in your mind the third dimension of the image, like a photograph, okay, to avoid any mistake in the orientation of your endoscope and, of course, your instrumentation. So, this clinical case is finished. The next patient is now in not already prepared, but c'est en cours. So I suggest a short coffee pause, okay, for 10 minutes, and we start the next case. And the next case is, I don't remember, I think it's fungus ball in the right maxillary sinus, or I don't remember. Sorry, I'm going to the list of patients. Yes. The second patient is fungus ball in the maxillary sinus, so it will be a short surgery, but very frequent surgery. And the third patient will be a sphenocoronal polyp. Okay. And between the both, I will show you the first patient on the other operating room, which is already done, but we made some movie to show the clinical case and the surgery. So between the both, we show you the fourth patient, which is revision of draft 3, okay, with navigation. So 10 minutes for a short coffee pause for me also. So rendezvous at 11 and 10. Okay, see you.